And I think in healthcare, when we focus on competing with each other, we actually don't add value. It doesn't get us where we need to go. What's the real competition? It's not for Intermountain, the University of Utah. It's not the national players even that are coming in with technology to reach patients. It's disease. In healthcare, our competition is disease. And when we frame it that way, and when we view it and think about it that way, yes, I'll compete with the University of Utah on certain services. That's great. And I hope we both do really good at it and the community will benefit. If we focus on disease as the competition, it opens all kinds of doors for collaboration.
Thanks for coming on. It's good to see you. How long have you been the CEO now?
A little less than 2 years.
How are you enjoying it?
Most days I really like it.
What's it like? Like, what was it like to assume that role? Because you'd been there for a while, right?
I have. I've had over 28 years experience with Intermountain Health and a lot of different roles, mostly in hospitals, some corporate leadership, and most recently, before becoming the CEO, I was the Chief Operating Officer. So I've been very involved with the high-level strategy, been very involved with trying to make sure we're coordinated well and how we deliver care on the front lines every day. So Intermountain wasn't new to me. But, you know, when you take on the position to lead the company, it is different. It is very different. And for Intermountain, for me, it's even more different than I think any other job out there, partly because I have a long history with Intermountain and have deep respect for the leaders who went before me, who built it since 1975 when the Church of Jesus Christ of Latter-day Saints gifted its 15 hospitals to the community through the formation of Intermountain Health. Those roots and, frankly, my heroes that I always looked up to who led the company were folks that I never anticipated, you know, sitting in their chairs. And so that added, I think, a little extra weight. And then just our mission, taking care of people, is so important to wanting to make sure we do that well. You feel that in the role here. All of that, you know, kind of weighs it down. At the same time, you have these 68,000 amazing caregivers who are committed and focused to purpose and to mission. And all that inspires me and lifts me up. So, you know, those are the things I feel every day.
And since you've taken over, a lot of things have happened. I mean, you have the new children's hospital in Lehigh. You went through a rebrand. I mean, you didn't change the name IHC, but you went through, there's like a rebrand. Talk to us about that. What was the idea behind that?
So the rebrand particularly was a reality of where we are today. So the early 2000s, about 2004 or so, there was a branding update done for Intermountain Health, and all of the signs and things around the organization are dated. They were coming up on needing to be updated, replaced. And at the same time, we were going through a merger with SCL Health and engaging and bringing on hospitals and operations in Colorado and Montana and Wyoming. And so that was under a different brand. And we had acquired a medical group in Las Vegas that was under a different brand. And we had acquired an air transport, medical transport system that was under a different brand. So we needed to bring all that together. And it was an ideal time to update and just consider what allows people to connect with Intermountain the way that we want to connect with them and the way they want to connect. And so we did a lot of market research and found that an update to the brand would make a lot of difference for people just connecting with Intermountain. I had to chuckle. I'm a bit of a traditionalist, and I feel deeply about our history, and as I've already mentioned. And so an update to the brand was a little hard for me to swallow looking at it. But what we learned was that the brand that we now have connected more broadly with our community. People felt it was more approachable, felt it was more caring. And so, you know, things change over time, and we were at a new space that, given the fact we were going to have to update signage, update a lot of things. If we were going to do that, let's do it in a way that's meaningful and connects people, and people that had been associated with the system for a long time. Some liked it, some didn't. What we have found virtually everywhere where it's a new connection for people, they like it. They feel connected to it. They feel like it's something they want to be a part of when they need healthcare and need a partner along their journey. So it's been good.
The company does have like such a unique history. You touched on it a little bit with the Church of Jesus Christ of Latter-day Saints owning 15 hospitals and then creating this group and pushing it out of the church into IHC, right?
Yes.
The church has an interesting thing. Like they also own Designs Bank for a while, and like all these what went in, just for those who may have just heard that for the very first time. Because when you said that, I was like, oh, I don't know that a lot of people know that. Do you have a sense for like why all that took place and why in 1975?
I've heard stories, so I'll relate the stories I've heard, and I can't validate I wasn't there at those decisions and those processes, but I have had the opportunity to spend time with every CEO in Intermountain's history. I'm number 5, and Scott Parker was the inaugural CEO. So when it was formed, the church creating this new organization asked Bill Jones, an individual here in Utah, to be the chair of the board and to help form a board that was broad across the community. And then that board hired leadership and Intermountain, took off from there. Scott Parker was the inaugural CEO. And so Scott shared with me some information in a sit down I had with him last year. So I hope I get this right, but directionally, I think it is correct. Some of the documents are very clear in the history that Victor L. Brown was the presiding bishop. And things that I learned through those recent meetings was the presiding bishopric was looking at how to better manage their time. And with 15 hospitals, I understand that each member of the presiding bishopric, 3 of them, chaired 5 of those different hospital boards. So each of them were chairing 5 boards.
Wow.
And I believe the board was made up of stake presidents in the area where those hospitals served. That was a big responsibility on top of everything else they were doing. And those who know the structure of the church know that the presiding bishopric is responsible for the temporal things. And then they have ecclesiastical duties as well. And so, they're doing all this business stuff during the week and traveling on the weekends, taking care of ecclesiastical things. And my understanding is they brought in a consulting group to take a look at what they were doing and to see if there was a way they could find efficiency and balance it better. And out of that, a question was raised by this consulting group of, is healthcare part of your core mission? Is this really part of the core of what you're doing? And the church was in a space that it was growing internationally. And the hospitals were primarily right here, the early settler communities where they needed those services, and the church organized to help provide them, which, by the way, is a very common story of hospitals across this country.
Yeah.
And so it had started here. And I think out of that, apparently came these discussions about, should we keep that? Should we move on? And it was determined to let that be a community-focused thing and the church focus on its ecclesiastical work. And in that process, it's been rumored that an organization offered the church several $100 million to buy those hospitals. And the church felt they were created for the communities. They should still be the communities. And so the not-for-profit structure of Intermountain Health was organized and the gift was given, and then the organization went forward. What's remarkable to me in that process is when the gift was given, there was one charge. The charge given to the new organization was to be a model health system. That was the charge. And that's become our vision as an organization. And it's driven us for nearly 50 years now. Next year, we'll celebrate 50 years as an organization. So cool. And it's been the driving force behind what we do. How do we keep doing that? And Bishop Brown also said, be a shining light to the nation in the work that we do. And Intermountain, a number of things that have happened under leaders and folks focused on the community have led to that in many ways. But we keep striving to be a model. And I think it's important to note there are other models.
Yeah.
We're not trying to be the model, but rather can we add to clarity of path for how we move forward to serve our communities well. And that's kind of that history as it evolved. And the other thing that was said, and I find this remarkable too, the church built these, led them, gifted them to the community, and they gave the charge. And then they also said, we place no restrictions on you except those you place on yourselves. And they really let the organization move out and become part of the community and simply be led and served by the community and at the same time serve the community. So
yeah, the community focus is incredible, how engaged. You see IHC everywhere, right? And like supporting various, local sports teams, like our big kind of professional sports teams and everything in between. That part is always incredible to me that you guys are so engaged in that. Obviously there's some advantage to that because you get your name and awareness out there and stuff like that, but you could do that in a variety of different ways. Why do it through the community building way?
So when we look at our partnerships in the community, and sports is an interesting example, we look at it from several angles. Does it help the community from a health and wellness perspective? And sports is a way that motivates folks to get active, right? So that's a really good thing. It's also a space that you look at all of the club teams, you look at all of the high school teams, right? I mean, the sports players, there aren't a lot of them. They're obviously really good at what they do and they obviously need healthcare, but it's a way to connect with the community. And so from a value proposition, we can get our health and wellness message out in an effective way. We can also connect with people in their care journeys that they need. And we have a pretty robust process of determining where we sponsor and where we partner to make sure that it adds value in the work that we're doing. And when it doesn't, then we'll shift and go to a different course. But for us, it's about going upstream. Our mission is helping people live the healthiest lives possible. And these avenues are a way to connect with people, create understanding. We launched a partnership with Salt Lake Real. And what we found there was a demographic in our community that is tightly aligned with the soccer world that we weren't reaching effectively. And that relationship has opened a lot of doors for us to reach that part of our community and focus with them on their health and wellness journey.
Yeah, you guys are on the Jersey, right?
We are.
Yeah.
Yeah.
Yeah, that's incredible. What do you think of BYU's new medical school? Just like going back to that, like they kind of gone a little bit back into healthcare, although I think it's focused on like international stuff. What when you heard that announcement, what did you think?
Well, we're very excited about it. So part of that announcement was Intermountain Health as a partner in that, and we will be a clinical partner. I think the church and BYU are not looking to start hospitals, but they need that. They need the clinical partners to do the school. So if you look at the demographics and the statistics, if we at Intermountain Health recruited every doctor trained in the next 10 years in the 6 states we operate in the interior West, we would not have half as many doctors as we need to cover the growing population, the aging population, and the retiring physician population. So there is such a need to do this. And, one of the things I worried about with the announcement was, would the University of Utah feel like we're moving away from our relationship with them? So I think the first phone call I made as soon as I could make that phone call was to leadership at the University of Utah to say, guys, we're still in. We need to train doctors together, and we need a lot more. So we're going to work with BYU. We're going to continue to work with you. The University of Utah has announced some expansions in Southern Utah. We'll continue to look to partner with them on those training programs. And BYU's medical school will just add. Even with BYU's medical school, it's not going to train enough doctors for what we need. So we need this. We're excited about it, and we're anxious to be that clinical partner here in Provo.
That's incredible. That's actually an incredible stat. Like that wouldn't even be half enough of what you need. Like that. What do you make of that? Like, why are we not getting as many doctors as we need? It's obviously really hard to become a doctor, but
let me go broad with that, right? I mean, we'll come back to the doctors, but I don't mean to dodge this, but I think put it in perspective for our listeners that the healthcare arena is short-staffed today and will be more short-staffed in the future. And this is a combination of a number of things. The demographics, the aging demographic is part of it. So we have a lot of folks who've been in healthcare who are retiring. We have fewer younger people today to take care of the older people. And I'm going to be one of those old people before long. And, that worries me a little bit. But in our community, we have this model of care that requires a lot of hands-on. And healthcare is a hands-on business, and that will never change. But we're going to be short nurses. We're going to be short doctors. We're short rad techs today. We're short med techs in the labs. We're short the frontline service staff as well in our cafeterias and keeping the facilities clean. And when we look at the demographics of our country, we know that we're not actually going to be able to replace all those folks at the level we need. Now, part of it is the number today, but the number we need in the future. So, you think of people, the retiring, the baby boomers, you really don't draw a lot of additional healthcare services when you turn 65, but you do when you turn 75. So we've got this aging group that's coming. Some of them are at that point. We got a whole bunch more coming, moving into that. And over the next decade, we're going to have a need for a lot more people. And so when we look at doctors, we look at nurses, we start to ask the questions about how do we support our caregivers so they're not overwhelmed? And how do we change the model of care so we can do it with the number of hands we're going to have?
Yeah. What's interesting, I think we kind of all saw this, or just like the general public, like during the pandemic where it's like, whoa, hospitals can get full. Like they can have a shortage of nurses. That's kind of fascinating. What do we do about that? Like, how do you solve that?
So the pandemic's interesting to look back at, and it was an interesting time in healthcare. A lot of people who were going to retire didn't. They stayed in play. And that's natural for caregivers. I mean, it's in their nature to say, there's a crisis, I'm in. I'm here. I'm going to help my team. And so we weren't surprised by that. But then as it went through the pandemic, we heralded these folks as heroes, as we should have as society. Sure. It was remarkable.
Absolutely.
In fact, I'll never forget the first story I heard that just tugged at my heartstrings when the pandemic was rolling forward and we started shutting down services that were elective in order to make sure that we were taking care of the high-risk folks, the folks that were, needing our hospital services. And doctors and nurses were showing up every day in the face of not knowing what this disease even was. And in those early iterations of the virus, death rates were much, much higher. We sent 150 people to New York City, and it was the big place hit early on. And
that was incredible. I forgot about that. I remember being really proud of that.
Well, I'm proud of it. And our caregivers, what amazed me in the face of all this, we had slots for 100 to 150. We filled all 150. We had nearly 1,000 people immediately volunteer. And these are the folks that they're there to take care in crisis. That's what they do. And they were ready to go. We learned a lot by going there. So when the numbers increased in Utah, we were much more ready. That was a good thing. And by then the virus had mutated some and it wasn't quite as devastating here, thank heavens. But we went from these folks being heroes to the politicization of the pandemic, which was the saddest thing in all of that to me. This wasn't a political issue, but it got politicized.
Yeah.
And so we had different factions that then started to get emotional about where they were. And we went from thanking these folks to, if they mentioned the word COVID, some patients would punch them in the nose.
Yeah.
In the ERs, doctors, nurses.
Really?
Oh, yeah. The violence went up pretty dramatically.
Oh, my
in the last
word.
part of the pandemic. And so when the pandemic started to wane, those folks who put off retirement retired. And we had other folks who weren't going to retire that soon who then retired as well because it got violent. And it is a sad thing. Workplace violence in healthcare has gone up.
That is nuts.
And it is very sad.
I had no idea.
Yeah, we worry about the safety of our caregivers. Well, that exacerbated the shortage. So it was coming anyway, but it exacerbated it some. And so we've been scrambling. We've been in a good spot here, frankly. Our nursing turnover rates were about a third lower than the national turnover rates during that time. And so we weren't as impacted, but still our caregivers carried a heavy load. And we've been looking at how do you lighten that? How do you move that forward to make the jobs more doable? I talk about making them simpler and easier. I always have to pause and let our doctors and nurses know I get the fact that giving care is complex, understanding the human body and doing that is all complex, right? So, but in the midst of that, we had a doctor in the early pandemic. This was the story I wanted to share, who came and reported. We were running, as the chief operating officer at the time for Intermountain Health, we stood up and ran a command center 24 hours a day for 2 years. Mm-hmm. And myself and 2 colleagues rotated, leading that around the clock. And we had daily reports, huddles, updates to know where to deploy resource, how to support our teams. And we had a doctor who shared the story, reported that he had been working at the hospital. He didn't want to carry the virus home to his family. So they had visqueened off the door to the basement of the house. He was living in the basement and relayed how hard it was for him the day before this report to listen to his 5-year-old's birthday party going on upstairs through the visqueen when he was quarantined in the basement of the house, all for the purpose of making sure he didn't carry the virus home and get his family sick. But those were the sacrifices people were making. And all that was on top of the stress everyone felt in the pandemic, right? Yeah. Everything was shut down. You had risks, challenges. Yeah. Healthcare workers were working, but they may have a spouse who then wasn't able to work, right? Yeah. And so they might have financial challenges even though they were working. And it was interesting to hear that. And that made it very real. This is what these folks were doing. They were going to work in spite of the risks, the fears, and they were making huge personal sacrifices.
It's actually beautiful. It's really incredible the way you all stepped up. And like, I was going to mention this too. You mentioned the University of Utah. It's really quite incredible how close you two are. Yeah. And work together so seamlessly, even though technically I guess you're competitors, but it never really feels like that.
Good. I'm glad to hear that. At times it has felt like we're really competitors in the process, but I'll share my perspective on that. And, we have a lot of relationships with the U and we intend to continue to expand those. Mm-hmm. Utah needs a very healthy, strong Intermountain Health, and Utah needs a very healthy, strong University of Utah, both the university and the medical center there at the university. So we want to partner much more than we compete. But years ago, I was charged at Intermountain as a vice president to lead the development of our telehealth services. Mm-hmm. And Charles Sorensen, who was our third CEO, Dr. Sorensen, had charged me to get something launched by the end of the year. That was the charge, right? About February, he came and said, by the end of the year, I want this telehealth product up where people can get urgent care through telehealth. And it was a great concept. And so we started to build what we could do with this. We looked at the real need, and it was interesting, the need. The year before at Intermountain, we had 53,000 patients treated in ERs that didn't need to be in ERs. They didn't need to be in our Instacares. They didn't even need to be in their physician offices. For what they got treated in the ER for, they could have been treated remotely on video screen with a remote physician under a product we now call Connect Care. But we were doing studies in the market. So it was August of that year. We went out and no one was advertising this. No one was offering it in Utah. And of course, our big competitors were the University of Utah and HCA and a number of others. But we surveyed the community, and 26% of Utahns knew this service was available somewhere. 42% of those who knew had already used it. And I suddenly had this epiphany that the people we thought were our competitors in the valleys are not our competitors. We have national people dipping in here, taking care of folks, disrupting flow or however you want to view this competition. It was a different world all of a sudden. And I've opined on that over a number of years. And I've further developed my thought around that, frankly. And I think in healthcare, when we focus on competing with each other, we actually don't add value. It doesn't get us where we need to go. What's the real competition? It's not for Intermountain, the University of Utah. It's not the national players even that are coming in with technology to reach patients. It's disease. In healthcare, our competition is disease. And when we frame it that way and when we view it and think about it that way, yes, I'll compete with the University of Utah on certain services. That's great. And I hope we both do really good at it and the community will benefit. If we focus on disease as the competition, it opens all kinds of doors for collaboration.
Silicon Slope Summit is Utah's original and longest-running grassroots tech event. It provides entrepreneurs, startups, and leaders the resources and community they need to succeed. With the pandemic behind us, we're excited to bring Silicon Slope Summit back to its original January dates in conjunction with the Sundance Film Festival. We have some unbelievable news. Silicon Slope Summit is free for all Utahns for the first time ever. You heard that right. Silicon Slope Summit is now free. For those looking for an upgraded experience, we are also offering VIP tickets for just $95. Thanks to our partners, sponsors, and government leaders, Silicon Slope Summit is the most accessible tech and startup event in the world. Summit will be hosted in multiple locations throughout the week in both Utah and Salt Lake Valley. There will also be a Startup Alley at Summit this year, where startups and entrepreneurs can meet with investors from around the world to pitch their ideas, receive feedback, and promote what they're building. Of course, we'll be bringing in world-class leaders and speakers, as we have in the past, but we'll also be hosting specific tracks and bringing attendees together for curated networking in a way never done before. You don't want to miss this year's summit. To register, buy VIP tickets, learn about sponsorship, and apply for your startup to be part of Startup Alley. Go to siliconslopes.com/summit.
I had a summary done by my team here recently just to understand the scope of our relationships with the university. We have over 900 different contracts for related services between our organizations. And I think that's phenomenal.
Yeah,
and it should be, and we should expand it. The biggest, of course, is our partnership with the Primary Children's Hospital, where the medical staff is largely the pediatric department at the University of Utah. And we have the hospital and we lead the operations of it, but they're our full partners in delivering care. And as we've expanded into Lehigh, that's been a really important partnership to expand. And they've been great. They're great to work with.
Yeah, that's incredible. You mentioned like technology coming into healthcare and thinking about like telehealth and what eventually became a product. As I look at AI and the way AI is kind of rapidly developing, I can't imagine an industry that will be more transformed by it than healthcare. How are you thinking about it?
I hope that's true, actually. A number of years ago, I heard this statement. I don't know how true it is, but it always intrigued me. And the statement was, there's only 3 industries in this country who have not found productivity improvement through technology advances. And those 3 are government, education, and healthcare. I don't know if it's true, but it sure feels directionally correct, right? And as we look at this in healthcare, the technology advances have been extremely important in our ability to do better medicine. You get new technologies, new imaging, new labs, all kinds of things that help physicians identify and treat and cure. That is important work for us, but every step in that actually increases the cost. And so we've got to find a space where the technology, like other industries, actually brings the cost down. And I think AI starts to bring to us that opportunity and that promise. Now, there is caution with AI, and I want to note this on the front end because I'm going to tell you how excited I am about it all. But there is this risk with AI, and people know it and they hear it. And in the healthcare world, we want to lean aggressively into AI use with a lot of caution around guardrails. So we're not looking for AI to replace our doctors and our nurses,
Right.
but we're looking at how it in the back office functions can make it easier and smoother, make it simpler for patients to go through their journey of care. In the care side, we're looking for these tools to support our doctors and nurses. And I'll give you some examples in just a moment of what that is. But this gives us the chance to do things we didn't even dream about 2 or 3 years ago. And all of a sudden, this is exploding in its capacity and ability. So we've been looking at how do we use that to help us address this shortage of hands? How do we use it to redesign the workflows? And here's some examples. And the back office stuff, people hear this in all kinds of industries, so I won't focus there. I'll focus on the clinical side. A year and a half ago, we piloted a tool called, it's an ambient listening tool for our physicians to make their lives easier. In the pilot, 97% of our doctors liked it. 3% did not. And those who didn't primarily referenced the training period. So to train this tool, what happens is when you're in the office, if I came to visit you and you're my doctor, Clint, you might pull out your phone and say, Rob, we're going to go through our visit here and I'm going to turn this on. And this is actually going to pick up our conversation and do my charting.
Yeah.
So I can focus on you and not focus on some chart, writing notes or typing notes. And so it just gets set on the counter. The training process of it is it recognizes the different voices, but at the end of the day, the doctor has to sit down and look at this transcript and highlight what she wants to have in your chart. And that starts to learn. And over the course of months, the tool learns what you want documented.
Interesting.
And once it's trained, doctors now, when they're done seeing you, their charting is done. Versus the old way, just a year ago, doctors would see you, they would take some notes. At the end of the day, they'd have to come back and kind of complete their charting, wrap things up. Doctors reported on average about 2 hours a night that they were doing charting. In fact, I had a doctor down in Delta that I've known for a lot of years that he said, Rob, ever since I've had a computer, this is my routine. Now, this is a rural doc. I go to the hospital early in the morning, about 6:30. I make rounds on my patients, see who's in the ER that I need to take care of. Then I go to my office. I see patients through the day. When I get done, I go to the hospital. I do rounds again to make sure I wrap up anything patients in the hospital need. And then I go home. I have dinner with my wife. And then I open my computer and I spend 2 to 3 hours charting, cleaning it all up. And then I go to sleep. Then I get up the next morning and do the same thing. That's exhausting. And what we heard out of these doctors that were trialing it was it changed their life. They suddenly had a life back. In the evenings, they could be with their kids. They could have dinner with their family. They could do their own personal hobbies, whatever they needed. And the next day, they were actually rejuvenated. I had a couple of doctors tell me that it saved their career. They were thinking about getting out of medicine. They were so frustrated by all of that. And so that's just one tool applied. Now, as of May this year, every doctor employed at Intermountain Health has access to that tool if they want to use it. And so it's available to them. We're also now trialing and using a mailbox tool. So your relationship with your doctor continues to change with technology. And now many people can communicate via email with their physician. Well, that takes a lot of time then at night for the doctors to go through that. They'll be in clinic all day long, and then they have to deal with all these emails as well. We're now using AI to draft responses. By the way, studies were shown recently that patients prefer AI drafted responses. On average, I'll say that, on average, they come across a little more compassionate, which is kind of a really interesting study. And I suspect it has to do a little bit with the pressure physicians are under trying to get through all of this load, right?
Trying to get through it.
But what we found as our doctors have been working with us and trialing it in part of our organization is they're saving 47 to 48% of the time it otherwise took to respond to emails. And what this tool does not replace the physician. It does not automatically respond to the patient. It looks at the email. It looks at your record, so it's personalized. It looks at general body of medical knowledge, and it crafts a response based on all of that information and the questions you ask the doctor. The doctor then comes and sees your email, sees the drafted response, has 3 choices. Send it. That's perfect. Just send the response. Edit it and then send it. Throw it out and write your own. And that's their choice. The physician can choose what they think is best, but that's cutting almost half the time out of that task.
That is, and their patients are probably getting responses faster.
Yes.
Thanks to
the
it.
Doctors are able to stay on it They're do it quicker and I think able to stay on it more readily. The other thing that we're doing now is saying, what can we do with this in nursing? Right now, we're piloting in 2 units in Colorado, our nursing units, a tool that is similar. It's the same concept. How do you use AI and ambient listening for nurses to enhance what they can do with patients? And this is part of a journey that we're on. We challenged our nurse executive, Mandy Richards, this last year to look at how we could redesign the nursing workload so that we actually could do it when we don't have as many nurses in the future. So she went out and looked at what are we going to be short in nurses. By the way, in Colorado today, the state is short about 10,000 nurses in the state of Colorado. In Utah, we think in about the next 4 to 5 years, Utah will have about 10% fewer nurses than it needs for all the factors we've talked about already. And so how do we design it so nurses aren't burnt out? And how do you design it so they find more joy in what they're doing? Our studies showed nationally, there's published studies that nurses spend 30% of their time at the bedside. That's the average. Now, I don't know a nurse who got into healthcare to only spend 30% of his time with a patient, but that's what the national numbers show. Our studies showed earlier this year that at Intermountain, our nurses spend about 36% of their time with patients. So we're 20% better. Nice. But our charge to Mandy was, how do you change the model to accomplish 2 things? Number 1, be able to staff with the number of nurses we have without overwhelming them, change the work so they can do it. And number 2, at the same time, put them more time at the patient's bedside, right? I don't want this to be, great, we did it. Now you're at 20% with the patient, you're doing a lot more administrative. How do we actually swing it the other way? We now have a plan. Her team, and a lot of our nursing leaders in the system have been involved in this, have looked at all the pieces and steps every day, every shift, and looked at where we can actually gain improvement. And now they're going through the process of building that, which will be a multi-year journey for us. So one of those is this tool with our nurses. How do you help them with their charting? So a number of years ago, we moved to computers, a lot of years ago, right? This is all in my time in healthcare, by the way, but we moved to computers. Then we moved the computers into the room next to the patient. Why? Because the nurses were spending their time out of the room. And so let's put them closer to the patient. Well, they're still focused on the screen and the keyboard, not as much on the patient as they'd like to be. Well, what this has done is this is a tool they turn on. The nurse tells the patient, I'm going to turn this on and it's going to do my charting while we talk. And then they can actually just talk about what's happening for the patient. How are you feeling? They get the patient's answers. They say, here's your temperature, here's your blood pressure, this is what your heart rate is, all the things that they, in the current model, what we want to be the old model, had to then go to a computer terminal and type in. And how can we look at this? We also, by the way, have telehealth cameras in all these rooms that are so finite a doctor can diagnose your eyes from across the room. What can we use for that to pick up data as well and put in the chart? But what we're doing right now is just this dictation tool, and the nurses talk with the patient and the charting's done. Now we're in the middle of pilots, but we filmed some nurses' responses to this, and they are excited about what this possibility is. And what they're reporting is they have a better relationship with the patient. They're having real conversations instead of worrying about, am I capturing this piece of data and this piece of data? And when they get done, they pull up their phone and all of the charting spots are filled. It's picking up and putting in the right places the information that's there. The patients are reporting. They feel more cared for and attended to by the nurses because the nurses are talking to them, not behind a computer screen. The nurses are spending more time getting to know them. The nurses are saying, I know more about this patient, not just the disease I'm treating or the injury I'm treating. I actually know more about who they are because we're having those kinds of conversations. We're really excited about where this is going to go. And this is all taking the opportunity to use technology, make sure we've got the guardrails around it, and do it in a way that's focused on making jobs more enjoyable and doable when we realize we're not going to have as many people in the future to do the jobs that need to be done.
Yeah, that's why I say I don't know of another industry that AI will impact the most, at least to start, than healthcare. Yeah. And it's primarily, I think people sometimes think it's like robots doing surgeries or something. That's not what we're talking about. There's so much data that needs to be collected and managed and secure and all that type of stuff that AI would do an incredible job doing that with. And you've explained some of that. What do you, like, as you look at these technologies, how much do you try to develop them internally versus going outside to come at some of the Silicon Slopes companies or national tech companies?
Yeah. I'm excited with how much innovation is happening here. And we certainly cannot develop all this ourselves. Interesting history with Intermountain that most folks may not know at all. We had one of the first electronic health records in the country. So Intermountain in 1978 at LDS Hospital in Salt Lake launched the HELP system. That was the name of the electronic medical record, the HELP system. And it had a couple of iterations, and we stayed on that until well after 2000. And the technology was so dated. We had a HELP 2, the updated version, but ultimately had to shift out of that, right, and go to other things as it continued to evolve. But we did evolve all that. And we at times have built our own tools quite effectively. It is so fast changing now that we don't believe that we should put all of our energy into developing it ourselves. We're really looking at partners and who are the partners who can carry that for us. And we're looking to align where that is and keep flexibility to adapt new technology as it goes. We will help people develop it. In fact, these pilots in Colorado are a partnership with Microsoft, and we're one of 5 locations in the country helping them develop this tool. So we think we're in a position that we can use our expertise, our clinical processes, where we get recognized nationally for those things, to help develop tools that help us solve our problems, developed by the experts who are actually developing this broadly, not just the healthcare piece. And we can keep our focus on patients and patient care and move forward the needle around the redesign and moving to a better space. And by engaging our nurses and doctors in development, we believe we'll get the tools more structured to our needs. We also find when you look at the fear of AI, there's some interesting studies that keep coming out. I'm sure you're well-versed on many of them across the broad industries, but in healthcare particularly, if nurses or doctors are involved in, they have much higher confidence in what it will do. From the community side, there's some concern about using AI for medical care, right? If it's back office stuff, you're going to use AI to process my bill, I'm okay with that. But in the medical care, there's concern. But if it is framed that your doctor uses it to help them do their job, the acceptance is much, much higher. And we think that's the right model. So let's involve them in designing the tools. Let's make sure the tools support our clinicians doing their job, not replacing them. And we think we'll have a space where patients, community are comfortable with it. Doctors and nurses are comfortable with it. And we can truly leverage those tools for the benefit of what we're here to do.
Have you ever thought of like doing like a health tech accelerator or something like that? Like where, you know, IHC would get pieces of these companies, but they're also like kind of, you're helping like kind of guide what the industry actually needs?
So we have an arm at Intermountain called Intermountain Ventures.
Oh, so you do this.
We do this. We do this. And in fact, we scan about 600 companies a year. And we use ventures to do 2 things, to help us understand what's going on in the market and to help us be involved at the right places to help develop the tools. So we scan it. We at times get warrants in these companies for helping them develop their products, et cetera. Those are nice pieces, but the biggest value for us is seeing where things are going, being able to be a place where things get piloted so we can help influence how it's developed to meet the needs that we see. And we've had some good success with that, but we scan 600 a year. We don't engage 600 a year, but we're engaged with a number at any point in time developing their products.
That is, that's genius. That's exactly what you should be doing. That's awesome. What does a typical day look like for you as CEO? I can't even imagine. Is any 2 days the same?
No, every day is different. And it's interesting. When I became CEO, I was given a lot of advice. When I was applying for the job, I did a lot of study, talked to a lot of people trying to understand the jump from being a chief operating officer or a hospital CEO, which I had done most of my career, to being a system CEO. And there was a number of pieces of advice that came, and I found them fascinating and I found them remarkably helpful. And I've seen along the way where I didn't take the advice quickly, how I should have taken it quicker. But there were a number of things such as be quick in developing your team. So you've got folks and you're all together so you can move forward. There were things that people would give you advice on about, as a CEO, listen really carefully. More people will tell you what they think you want to know than what you need to hear. And so be really sensitive to any nuance so you can hear the right things. I can tell you at Intermountain, I've been remarkably thankful that our caregivers have been more candid with me than I expected them to be in this role. Now, I always felt like I had a good relationship in my other roles. Maybe that's why they were open. But as I went into the rooms, I spent the first 6 months as CEO just inside the system. I actually didn't do external things. I wanted to focus on our caregivers. And so we spent a lot of time meeting with them, talking about what's on their mind, what's your challenges, so we could work together to solve them. And there was a lot of candor in those rooms, and that was awesome. That was awesome. But that was one piece of advice, and I still keep it in the back of my mind. I don't want to miss the real things I need to hear. One of the things that I was counseled on was keep time open on your calendar so that you can respond quickly to the reality of the crises or the immediate needs that come. And that's been hard. That's been hard, actually. As COO, just before I became CEO, I did a study of my calendar, and it was fascinating. My average week as COO had 54 hours of meetings. So that was my average week. And then, as you might say, then you do the work. A lot of work gets done in meetings, but there was stuff on top of that. And I recognized I need to restructure how and where I spent my time. And that's been one of the biggest challenges as CEO, is making sure there's enough free space to deal with the urgencies that come, because they're there and you have to deal with them and find a balance. So we've been on that journey working through that. But my typical day starts about 4:30 in the morning. And by the way, that's not because I'm the CEO of Intermountain. That's because I grew up a farm boy in Wyoming milking cows, and that's just my life. And whether I like it or not, I'm awake by then, which is good time for me. So early morning, I often spend time studying and reading, looking at what's ahead for the day. My meetings will start as early as 6:30 or 7, depending on the day, and then go through the day and into the early evening. You often have events at night. It encompasses a lot of travel. I'm on the road quite a bit, and just even within the system, as I've mentioned, we're across 6 states. I was in Las Vegas yesterday. I'm excited about what's happening down there. We just identified the site for a future children's hospital in Las Vegas and announced that yesterday there. And it was a great event. And that's a space. Las Vegas is the largest city in the country without a dedicated children's hospital.
You're kidding?
No. And they have tens of thousands of kids who leave the state every year for care. So big need there. And we've had a footprint there. So we're going to expand that in coming years. And we're excited about that. And so it's just, where do I need to be? And the schedule's built around that. And I have a great support team that helps that all come together. So it is different every day. You asked the question, how do I enjoy it? And I think I said earlier, most days I really like it. And that's true. And there are those days when it's a challenge, but we're here for the right reason. We have the right people trying to do the right thing every day. And it is an honor to serve with them, even when times get tough.
What have you learned about leadership over the past 2 years that maybe you hadn't thought of or, experienced?
One thing with leadership, a couple of thoughts with it. The first is a statement that I heard. I think it was Governor Levitt. Mike Levitt is our board chair, and it's been a remarkable resource and support to me.
Awesome.
He is awesome.
Yeah.
And I love Mike, and he's got so much experience and insight. He made a statement a while back that just makes me smile every time I think about it. 2 steps ahead of your people, you're a leader. 10 steps ahead, you're the target. And really important to remember that as you lead, that you're leading people and that you need to work with and bring them along. They need to understand what you're thinking. They need to understand where you're going and why. And what's amazing is when you do that well, they just pick it up and run with it, right? Then it's get out of their way. You do that well, then get out of their way and let them do, because they will. And they're amazing at it along the way. So that's important. You get too far out ahead, then you've got to recognize, I got to go back, got to step back here and, make sure we're together. That's important. Another thing that I've learned partly in this role, it's certainly been emphasized in this role, but servant leadership. And I think servant leadership is important in what we're trying to do and where we're trying to go. I would say Scott Parker, the inaugural CEO at Intermountain, who was a very quiet leader, very thoughtful, very innovative, remarkably innovative. He's enshrined in the Modern Healthcare Hall of Fame in Philadelphia, but he was never one who wanted the limelight on him. And it was just remarkable to watch Scott. As I mentioned, these are the folks that were my heroes that I wanted to be like and emulate. And that servant leadership approach of, in a lot of the traditional models, it's, climb to the top of the pyramid and now I have the power and I wield the power. And the servant leadership model is, how do you lift others up and empower them? And in healthcare, that's the core of what we do, is care about others and serve with others. And I think that's a remarkably important part of success in healthcare, is enabling folks to do their jobs. And when you're Intermountain, we're 68,000 caregivers strong across 620,000 square miles in 6 interior West states. You've got to have folks who can pick up the ball and run on their own. And if they're waiting for command and control to guide them, we're not going to get everything done we need to do every day. So it's finding the right balance, not just under servant leadership, of where does the system strength add versus where do you need to make sure there's local ability to do what needs to be done right there. The magic of healthcare happens one-on-one.
Yeah.
It happens at that point of care. And it's a pendulum. And you can be too system strong. One day you can be too, loose and field able to do whatever they want to do in the field. Another day, the key, I think, is keeping the swing of that very tight. So the system brings value every day, and the caregivers have the ability to make the needed decision and do what's needed for that patient. They don't need to go up the chain. They don't need to ask, is this okay? In fact, one of our values is we do the right thing. And I think that's powerful. It frees up 68,000 people, I hope, feel because of that value that they can make the decision when they're faced with a circumstance. What do I think is the right thing? Do that. Are
you the largest employer in the state?
We are the largest private employer in the state of Utah.
Yeah. I mean, I was going to say, I don't even know who would be second in that.
Yeah.
That's a lot of employees.
By the way, 68,000 total, about 40,000, a little over 40,000 are in Utah.
Oh, I see. Okay. What do you think of the growth in Southern Utah? You mentioned Las Vegas. So that one's interesting too, because it's kind of becoming as much a Utah city as a Nevada city. I don't know, like Las Vegas is really becoming incorporated in what we're doing. I mean, it's only an hour away from St. George, right? So how are you thinking about that growth? Because that's got to be like one of the fastest growing places in the country.
It is. And we entered Nevada in Las Vegas in 2019. And we've been, of course, in St. George for most of our history. That was a hospital that joined Intermountain after the formation. So it wasn't one of the original 15, but it came on. And it's had a very strong presence serving Southern Utah. And of course, we've also got hospitals in Cedar City and over in Panguitch that are part of that network in Southern Utah. And the growth in St. George, it's remarkable to watch what's happening there. And if you look at the campus, just the hospital side, I remember when we were at the 4th East campus down center town, and it was just a little block down there. And now this very, very large complex level 2 trauma center doing remarkable work in all areas, high levels of care. That serves a very broad geography, right? So when we went into Las Vegas in 2019, we did look at how do we connect services from St. George into Las Vegas and coordinate. And we had a lot of folks from Las Vegas who would travel to St. George for care. And so we started to look at how can we provide that care in Las Vegas for them. We want care to be as close to home as possible. And so now Intermountain, because of our size, has organized ourselves into 4 major operating units, and 3 of those are regions, care delivery regions. So we have the Canyons region, which is central and northern Utah and southern Idaho, southwest Wyoming. That's one region based in Salt Lake City. We have the desert region, which is southern Utah and Nevada, based in Las Vegas. And we have the Peaks region, which is Colorado, Montana, and the eastern side of Wyoming, based in Broomfield, Colorado. But our region president in Las Vegas was our CEO at St. George Hospital for a long time.
Oh, wow.
Yeah. Mitch Cloward leads that whole work. So very tied there, of course, very strong leader. And we're just looking at how you coordinate care in a way that you balance that system strength and the local ability to address needs and balance the needs of understanding the local needs constantly, not just that point of care, but how do you make sure you know what the community at large needs? And you need folks that are right there, boots on the ground, and have the ability to manage, make decisions. And so that's how we're addressing it and continue to grow there. We have about 60 clinics across Las Vegas. We currently don't own or operate any hospitals in Las Vegas, but we acquired the second largest medical group in 2019.
Wow. But you're gonna do a children's hospital.
We are moving towards a children's hospital.
Yeah, that's incredible. Finally, because I want to be respectful of your time, we end every interview with this question. And that is, we believe the chances one gives is just as important as the chances one takes. When you hear that, who gave you a chance to get you to where you are today?
The very first person who hired me into hospitals gave me a chance. I was 25 years old when I became the CFO of a rural hospital. And I didn't have my master's degree, which was uncommon. I went to school at nights and got my master's degree. But that very first opportunity to get into hospitals is something I'll be forever grateful for. I wasn't qualified. I wasn't experienced. And yet somebody took a chance on me and gave me that opportunity. And it colors today my view of folks who are trying to get in the industry, who are trying to climb the ladder, who are trying to figure out if healthcare is even right for them. It makes a big, big difference to give somebody a shot, let them run with it, and my life has been blessed, and I hope along the way I've helped bless some other lives as well.
Oh, I'm sure you have. Thanks, Rob. Really appreciate you coming in.
It's been a pleasure, Clint. Thank you.